Welcome back to Pod Patrol with your host, Dr. Jeff Dikis. Tonight, I am joined by Dr. Devin Simonson and Dr. Bradley Abicht. Thanks for joining me, guys.
Thanks for having us, Jeff.
Yeah, I am super excited to reconnect with one of my oldest buddies, Devin, that you were my first friend in podiatry school. You are my oldest podiatry friend. And Brad, I've just met. So you are my newest podiatry friend. So my oldest and my newest podiatry friends at the same time. This is very exciting. You guys help run the Gunderson Health program, the podiatry residency up in LaCrosse, Wisconsin. Devin, you are the director. Mm-hmm. Why don't you tell everyone listening how you became involved as being the director of this program?
Sure, happy to. So very proud to share that I trained here at Gunderson and graduated in 2015 and was added to the staff and really just enjoyed working with the residents and students right out of the gate. And in 2017, so after 2.5 years of being on staff, I was approached by the director at the time, Dr. Dawson, David Dawson, and he was looking to have a associate director for the program. And so I joined on as his associate, and I think after 1 year, he asked, "So are you ready to take over?" And I definitely said, no, I want more time to learn the ropes here. So after 2 years, same question. And finally, after 3 years, he handed me the keys. So right at the start of the academic year in 2020, I took over as director of our program.
That's awesome. And it's got such a good reputation with you and Brad and Scott Carrington, and the students that go through there always speak highly of it. So you should be proud of the work that you guys are doing. Brad, how'd you become involved with the residency there?
Yeah, similar to Devin, I did my residency at Gunderson, and then I was exploring fellowships, got accepted for an AO fellowship, which subsequently got canceled. And so I decided to just stay on and start my job there. About 3 years in, I became our department chair. And then, from then, just been department chair since that time. I was lucky enough to have Devin join our, group. And, he's really brought a lot of enthusiasm, a lot of new ideas, really taken the residency in another level, another direction. So I've been really excited to have him move into that role and help our department.
Yeah, that's great. Devin, and you and I go way back to, I think, the very first week of podiatry school at DMU. We kind of linked up and became friends. And you're actually the one that introduced me to my wife. So you get to take credit for that.
Oh, believe me, I do take full credit for that. I probably should say I'm sorry, Ashley, but
no. We feel bad for her.
No, so my take on it, if you will allow me to indulge just a little bit, was that with Ashley's maiden name alphabetically, she and I were assigned to each other as the two DPM students at DMU in our gross anatomy group, and the five of us really got along well, studied very well together. My anatomy group they were just rock stars, all of them. And so when I studied with them, I got really good grades. Didn't always have the most fun. Sorry, Stephanie and Cadence and Curtis. But I mean, it was great. But then you and I really hit it off as friends. And when we studied together, we had a ton of fun. Didn't get as good of grades for a very brief moment. And I quickly said, we got to figure out how to merge these two. And so I approached the group and said, hey, I think we got room for one more. And after a little initial resistance, they agreed, and we brought you into the fold. And then our study group was just the best moving forward.
Yeah, that was
so we could have fun and get good grades.
A little balance there. Keep it fun, keep it but also learn, also pass the classes. So
yes.
Brad, tell us where you went to school and where you're from originally.
So originally I grew up here in LaCrosse, Wisconsin. That's where Gunderson is based. My father was a nurse anesthetist that worked at our same hospital, and he recently retired, about a year or two ago, but worked there for, I think it was 47 years.
Wow.
So he'd been there a while. So I was familiar with the hospital, familiar with the program, kind of knew I wanted to go back there eventually, or at least try to. Um, and yeah, ever since coming back for residency, it's just been, kind of a place I wanted to stay. It's a great place to raise a family. Hopefully we're adding value with our residency program and continue to build it into new things. But I don't know if Dr. Simonson ever told you how he really landed our program, or the story behind that, because I was freshly a new attending coming out of residency, and somehow him and his wife perfectly timed having a baby at our hospital while he was a student doing his rotation there, and I think that really solidified his presence at Gunderson, and the rest was history.
That's
So,
awesome.
yeah.
Yeah, I got to credit my amazing and incredibly organized wife for pulling that one off. But I do sometimes tell the students, if you really want to be memorable, here's what I did, and and it's always good for a laugh. But
She was doing all the hard work back in school too. You guys had a baby while you were in school, so she's been doing all the hard work this whole time.
yeah, she hard carries for us, but it's so I'm pretty lucky. You're not the only lucky one here on the podcast. So
Yeah, for sure. So let's go back to first year into second year of school back at DMU, and you came upon a difficult time health wise. Can you talk about that and what led up to that difficult time? And we'll go into more detail as you describe it.
yeah, sure. Happy to. So I was born with a congenital heart defect. So we knew from a very early age that I have a bicuspid aortic valve, and that had correlated with some aortopathy. So early on, when I was younger, they had diagnosed it with a dilated ascending aorta. And as I developed and aged, in my late teens, early 20s, they had started using the term aortic root aneurysm. And so during the summer between first and second year at DMU, my annual visit, I kind of carried a heavy surprise where I learned that the aneurysm had kind of crossed a threshold and was large enough that the cardiothoracic surgery team was brought into the fold, because previous to that I just seen the cardiologist, and they told me that it was time for surgical intervention, because, as I'm sure many of the listeners know, ascending aortic root aneurysm, if that were to rupture, I would not be here. And so I think it was shocking and it was hard, because I had never had a single symptom my entire life, and so at times in my life this felt like it wasn't even real, but I knew that it affected things I was allowed to do, activities that maybe I wanted to do as a teenager, like lift weights, get jacked, play football, contact sports. I was never allowed to do that because of my heart condition. And
that's why you didn't lift weights. Oh,
that's
okay.
why I didn't. But
what's my excuse? I don't have that.
I don't know. Yeah.
You might have a heart condition. I don't know.
But
Yeah.
I a very short bunny trail on that. One of our classmates and buddies, Nate Coleman, he started working me out in the weight room after my surgery, kind of with permission from my treatment team. But yeah, we'll go back to the topic. So yeah, I found that out over the summer. We tried to plan the surgery as soon as I could so that I would not have to miss time. And of course, surgery oftentimes is not scheduled based on the patient's preferences, but kind of a lot of other factors. And so I ended up attending the first 4 days of pharmacology as our first class as a second year, Monday through Thursday. And then Friday morning, I wasn't in class because I was undergoing my first ever surgery.
Yeah. And you had just found out that Megan was pregnant, if I remember correctly. So
good memory. That is
accurate.
Lot
of heavy stuff going on for you at that time, with second year starting and surgery and a baby on the way. So, and you had successful surgery.
Mm-hmm. Not without its complications,
but
yeah, overall successful.
It did not go overly smoothly. You want to talk about kind of the rocky road through recovery?
Sure. Yeah. I mean, I can give you my take. I'd be curious your take as one of my absolute closest friends during that time. There's days that I have no recollection because I was intubated in the cardiac intensive care unit for a number of days, and that was not the intent initially from surgery. But several days later, once I was stabilized and extubated, I had a very rough recovery, to say the least. I think the hardest part of the recovery, besides a lot of the expected things, was a unexpected, um, we'll just say, injury to my brachial plexus on my dominant upper extremity. And so, there's a secondary incision for the cardiac bypass machine that they accessed. And I had lost motor function in my thumb and pointer finger, and I had lost sensation in my fourth and fifth fingers as well. And so, um, and that took a long time to get better. As expected, after a big surgery, I was tired and weak and fatigued easily, and there were definite doubts of my ability to stay with our graduating class early on. I mean, if you recall, pharmacology allowed us one makeup test. And so I burned through that. I didn't quite make it for the first test. And then I took the makeup test, and then the next day took the second test. And that's where my heart is still just filled with gratitude toward my friends and study group, because you guys help take notes in class because I couldn't be at lecture right away, and really just made it possible to. I mean, you guys tutored me like crazy, and
I didn't do anything. Just so anyone listening, I'm not the smart one of the group. I did nothing.
well, it was very helpful, and while I'm not always proud or willing to brag about what I would consider substandard grades by my previous standards. I passed pharmacology. I got a C, and I was thrilled to death about it. That I was looking like after that class I was going to be able to stay with my graduating class. So. And I have to take a moment to thank Dr. James Mahoney as well. He became kind of my surrogate advisor. He was not my initial assigned advisor, but he quickly became my advisor at DMU, and he really made sure that I was able to continue on with the academic side of things during second year.
Yeah, I think that obviously anyone going through that is going to come out better on the other side, because that's a difficult thing to go through. So, we all had your back, but you were the one that had to, take the test and do all the hard work. So came out better for it on the other end, and everything eventually kind of settled down. And that's a scary proposition for a surgeon or a future surgeon, to have dominant hand complications. I mean, that's, there are some other worse complications, obviously, but that's at the top of the list of kind of maybe the intermediate complications that you can think of. So good for you for pulling through all of that, and yeah, scary situation. So thanks for talking through that. I think that's interesting to hear that. So let's spin it to a little bit happier topic. Brad, why don't you try to sell people on your residency? Why should students come through your program? What do you think are the upsides of your program?
Mainly just Devin and the fact that he's here.
There we go. Come see Devin. He'll show you his scar.
My motor function all came back, so I got good grip strength. I can show you. But
no, I mean, Devin, first and foremost, he's an amazing director, and yeah, I mean, what a thing to go through. That's a highly stressful time, and you come out of that at the other side, and you're only stronger for it. But honestly, like for our residency, I think the biggest thing is just we're well-rounded. Hopefully, when people come through our program, they are getting a well-rounded exposure to not only the things we've been doing for 30 years in our profession, but the new things, the most cutting-edge things. Whether it's reconstructive total ankles, MIS, we have wound care and limb salvage. I mean, it's just we have, I feel like, the plethora of things to be exposed to. And so when you come out of here, you're going to get well-rounded. If you want further, you want to dive into some kind of fellowship, you want further specific training, you can do that. But I personally, I feel like residency, that's what it's meant for, is to get you exposed and well-rounded to everything. And then you can decide on what you're good at, what you might have an interest in, and where to go after residency. But I think that's probably our residency's strongest thing is how well-rounded we are.
So, Devin, you take 2 residents per year.
That's correct.
And then you do have an externship. So talk to people about what the externship month is like when they come to visit.
Yeah, happy to. So we open up 2 spots per month. We generally start our externs with the kind of the early rotators. So from Shoal, I think they're usually the earliest to come out, or Rosalind Franklin in Chicago. So we get great students from there right out of the gate in January, and then we take 2 per month throughout the entire year. So as the other schools, DMU included, start sending their externs out. Really, we've gotten student externs from just about every school in the country, I think, within recent memory. And when the externs come in, we immediately do our best to make them feel welcome, make them feel oriented. Our current residents will kind of rotate duties with who gets to give them a campus tour, and then our externs, really, we try to give them, I would say, a sampling of what our program has to offer. Of course, like many programs, I think I definitely try to encourage our student externs really focus on what the residents get to do. There are some instances where we can be real hands-on, especially with our state-of-the-art training labs. So we have a simulation OR. We do wet labs and sawbone kind of simulated surgical labs twice a month. And so that's really a good time to get our students hands-on. And then where we can in the OR and clinic, students will see time in the clinic, time in the wound clinic, time in the hospital. We give them a week of call, and then certainly time in the OR where we strive to give them a balanced view of the program, really, so that they would know, is this the type of environment they could see themselves in for 3 years of residency?
Yeah, for sure. And I've been to LaCrosse. I really like LaCrosse. It's a really fun place to be. Brad, you're from there. Why don't you sell people on what you like about LaCrosse as a town? Because it's not necessarily, a big city. It's kind of like you got to want to go there. Hey, I heard Gunderson's a great program. I want to get to LaCrosse. Why don't you talk about LaCrosse for a minute?
Yeah, and I should probably interrupt, Brad, real quick. Love the shirt choice. So I think that says it all.
Well, I wore this for Jeff, actually, because I know he's a Hawkeye fan. So I was waiting for him to comment, but I guess you stole his thunder.
I love it. For those listening, it says I put the sin in Wisconsin. And I actually love Wisconsin.
Red, yeah.
And I hate Wisconsin as a team because of the rivalry, but I actually love Wisconsin as a state. Yeah. We have visited many, many times. There's a big racetrack up in the middle of Wisconsin called Road America that we have been up to go to some races many, many times. So I love the state of Wisconsin. But yeah, what about LaCrosse, Brad?
Yeah, in general, LaCrosse is bordered on the Mississippi River, so we are right on a tri-state area. So, I love Wisconsin, but I also love Iowa, Minnesota, and those 3 states are kind of home to this area. It's a beautiful area. We're right on the Mississippi. We got bluffs all around us. There's a lot of outdoor activity that you can do if you like hiking, hunting, fishing, just hanging out outside. A lot of things to do there. So I love it for that. Even in the winter, we have Mount LaCrosse here. It gives you an opportunity to snowboard, ski, that type of thing. And you're right, it's not a big city, but it's big enough where you have everything you need available to you. But if you want to go to a big city, Chicago's not too far on one side, and Minneapolis is not far the other. So, you can go to these bigger cities, and it's a quick day trip. But we have really good healthcare here too, and you'll hear people talk about that. We have Mayo here in our city. We have Gunderson here. We're just really blessed, I guess, with really good healthcare, and I think that's important. Not only working for a healthcare system, but getting your own healthcare and having access to that. So, you and your family, great healthcare access here. I don't know if you have something to add, Devin. for living here?
I will add, I got 4 kiddos, and man, they're growing fast. My oldest Noah was born, second year of podiatry school. He's my only kid that was born in the state of Iowa. The only one that wasn't born at Gunderson, funny enough. But my second kid was born here at Gunderson when I was an extern. My third kid when I was here as a resident. My fourth kid when I was here on staff as an attending. So, we get our care here at Gunderson, and it's just a great place to raise a family. The kiddos have so many activities available to them, and they all have their unique interests. And I just love that about where we live.
Awesome. So aside from the cookie cutter response, what are you looking for in an extern? So no cookie cutter, just, what are we looking for on externships? Show up early, work hard, be nice, be normal.
Sure,
all that stuff. But what do you guys, look for when you're evaluating these externs? Because I remember back in Pittsburgh, we'd get tons and tons. We get 4+ students a month. They all start to blur together, but eventually it can be like, no, yes, maybe, yes. And they just kind of sort themselves out. But what are you guys looking for?
Sure. You can edit this, right?
Oh yeah.
I did think about this. I thought a question like this might come up. Probably the least cookie cutter, least filtered answer, I would say is, and I mean this in the best way possible, we don't necessarily want, I'll just say gunners. And what do I mean by that? I want motivated, highly qualified, academically strong, and we get that every year. Mm-hmm. But I don't want and I mean, if you are that type of student, you probably know who you are, or really everyone else knows who you are. And I would say we want somebody who's teachable and really wants to be part of our team. Because if you don't fit with my residents, we've had it every year. There are externs that I adore and think I could get along with this person. I could train this person. I could have fun working with this person for 3 years. And the residents, if they all give me the, kind of the gladiator thumbs down, then fine, they're off the list. It's something where as a team, we all make these decisions together. So you got to be a cohesive team player. I don't know if that qualifies as a cookie cutter or not. I shouldn't say team player, but I think you get what I'm trying to say.
No, I think it's good. Brad, what are you looking for? What's a deal breaker for an extern that comes through? What are some things that the externs do or have done in the past that really turn off a program?
Yeah, I mean, similar to what Devin said, I think they got to want to be here. So if they're leaving earlier than I am, that's a red flag. Mm-hmm. Not that they should be the last ones to leave, but at the same time, just, they need to be working hard. They got to be able to be available, stay late, do whatever the job takes, really, because the job doesn't have just one set of criteria. It's kind of, it's fluid, really. And you got to get along with everybody. You got to just work hard. And I don't need you to know every answer. I don't need you to recite me every paper. But at the same time, you don't know something, go look it up. Work hard, like I didn't know everything for sure, and I still don't. I still got to look stuff up. I got to, pretend like I know what I'm doing. But at the same time, as a student, yeah, we want you to just want to be here, I think, and work hard when you're here. Same thing if you are a resident and you actually, come to our program. You got 3 years to learn as much as you can. And that not only means learning the good stuff, but learn the bad stuff. Learn the stuff that you see in your attendings and you're like, man, I will never do that. Yeah. You got to learn everything. Mm-hmm. And we don't always get it perfect as attendings, right? I mean, there's things that I mess up that I'm sure our other attendings mess up, but those are perfect learning opportunities for you to see that and then not do that once you get out on your own. So, and I think sometimes that's a little bit lost too, even when I was in residency, it's like, I thought my attendings, everything they did was gold. It was perfect. It was whatever. But then you start seeing these people in clinic and you're like, oh no, there are some side effects to this. There are some complications. There's There's
Right.
things you got to be able to talk to the patient and make them understand. And that's really where the game is often won, is not so much in surgery as it's in clinic. So you got to be able to talk to people and relate to them. So if you have a student that can't really do that, they're going to struggle. I mean, and that might be a long 3 years for both the student and you. But otherwise, yeah, the biggest thing, they got to want to be here. They got to work hard. And yeah, maybe that's a little cookie cutter, but those are probably the most important things I look for.
Yeah, for sure. I mean, I think I have students that rotate through with me, and I think one of the biggest things that I battle with them is them coming off as disinterested. I think the tendency for a certain generation is to grab your phone and focus on your phone. I don't know if you're on TikTok or if you're reading the Presby manual or something. I can't tell. All it comes off to me as is you're disinterested because you got your nose in your phone. So there's some trends that I've noticed, and I think maybe if you tell the students like, "Hey, you seem really disinterested," they'd be like, "What? No, I'm studying on my phone." So anyone listening who's out there, just be careful of how you come off, even if you are not intending to be disinterested. It's very easy with technology, whether it be your computer or your phone, to come off as disinterested. And that's a big turnoff to me. Whenever I get a student who seems disinterested, I don't go out of my way to teach extra. If they're interested, if they're engaged, if they're asking questions, what about that? Oh, that one looks cool. Like, why did you put that plate on there? I'm going to keep going. I'm going to talk all day long because it's engaging, it's interesting. So I think it's relatively easy for students to act engaged, and they should be. This is what they're going to be doing for the rest of their life. We're not studying something completely foreign. We're not, rememorizing the Krebs cycle at this point. All that information is long forgotten. These are the things that you're going to be doing every day. You should be interested. So that's
You mean
one
you
thing
don't remember that?
Not a
You don't
I
remember the
didn't
Krebs
remember
cycle?
it then. I didn't
We
remember it
studied
during
that
the
together,
test.
Jeff.
Wait, what's
Jeff.
this cycle again? What does
Yeah,
this thing do?
no. I love that. That sparked just a recent, a thought where, I guess not really recent. I misspoke. So that sparked a memory for when I was a student. I remember I was externing out at a different program, not this one, but great group, awesome teachers, and one of the residents, was doing journal club with the journals on his phone, and everyone else showed up with just I know this is going to sound super old fashioned. I promise I'm not that old, but they had printed paper copies of the journals that we were going through. We're going through about 10 articles, and they all had paper copies.
I thought you were going to say
And
BlackBerry.
yeah, not
Palm
Blackberries.
Pilot.
Yeah, it
That
was
would've been
one of those
awesome.
overhead projectors he carried in. No, but if you're listening, and you don't know what that is. Don't tell me. But so this one resident, kind of caught some heat from his director because he was, like, "What are you doing on your phone?" And he showed him, I have my journal articles, and that's fine. I show up to journal club here with the articles on my phone, but that always kind of stuck with me, that just having something to study, a book or a pocket manual or some paper copy of a journal. And then I think when you're on your phone and you're studying, if an attending or a resident or somebody is approaching you, it's very easy to be done studying. But if you're in the middle of some, TikTok video or something that, you're like, oh, if I close this Snapchat, I won't be able to see it again. And you are reluctant to peel away from the phone, then I'd agree that can be a red flag. And I think I just want to echo what you both said. The engagement is huge, because you could be the best student except for you're disinterested, and then it's just going to be a struggle, kind of no matter where you go, I think. And so, yeah, it's huge, just showing an interest in your chosen profession.
If I can add something to this too, entitlement kind of turns me off when people show up and they just expect something.
Yeah.
That's a big turnoff for me personally, because and close to Devin too. We went through a residency where we had attendings that certainly did not just hand us stuff. We had to work for it, and not that that's not happening today, but that is one thing that'll turn, I think, programs off immediately, is if you show up, not only are you disinterested, but all of a sudden you think you're entitled to whatever it is,
Yeah.
whether it's in surgery or clinic or whatever, I'd be real careful with that if you're a student or a resident.
Yeah, I completely echo that, and I've talked about that before, and I completely agree with you. Some of that I think is generational. We don't need to take a deep, dark rabbit hole dive into generational differences, even though I'd love to, and bash the generations below us. No, I'm just kidding.
Only because those before us bashed us. So
no,
yeah.
I mean, like,
yeah,
I think, part of it is residencies have gotten better, right? Like we have protected people better. We're not killing them with work hours and and that stuff shouldn't be happening. That's not what I'm talking about. I'm talking about you still show up, you work hard, you do what's asked of you, and there's not this entitlement. And
Yeah.
I think residencies are better that way now, but it is definitely different than what previous generations have gone through.
Yeah, I think there are students out there. I want you to hear this. You are amazing. There are so many of you that are just busting your tails, and it just takes one bad taste, one off encounter with an extern for some attending to just kind of get fed up and say, you know what, I'm done with externs, and it's not fair. And so I just want you to hear that. You keep putting that effort in. It'll be recognized, and we get so many good students that come through. It's one of the problems I often have. Truly, is I only have 2 spots to offer for match day, and year in and year out, we have so many people. I would truly, honestly, be thrilled to see their name on match day, but I only get to see 2 of them year in and year out. So it's one of those. Yeah, there's you have so many good qualities, and we're just trying to encourage you all to really put those best qualities on display.
Would you like to go ahead and release the names of the residents that you're going to be selecting this year at this point, or are you going to withhold that information?
Oh, yeah, it's such a hard decision every year. I'm just being honest. I love it. Honestly, one of my favorite things is going to CRIP, doing the interviews. I enjoyed it when I was a student, but I promise you I enjoy it more on this side of things.
Oh yeah.
The stress fest is real. So, I don't know exactly when this will be released, but if you're catching this on your way to CRIP or whatnot, you're a student interviewing there this coming January, just stay calm, believe in yourself. You put in the effort. Don't do anything stupid. Don't let the stress get the best of you. It is crazy, but I love it. The ability to see all the externs that we've interacted with for the past year. There's so many that I'm just genuinely looking forward to, and we're interviewing some non-extern candidates as well, and I just love meeting new students and hearing their stories and seeing what they're about. But no, Jeff, I'm not going to release those names just yet.
All right, I thought you might slip up and give a little breaking news on the podcast.
No, if anything, I want to put other programs on notice that we play by the rules here. And I think a bunch of the programs that are not following the rules and unfairly putting students on the spot, pressuring them into things that they shouldn't be pressured to, shame on the programs. They should not be doing that. And honestly, I know your old director, Dr. Burns, he wouldn't recognize me from Adam, I promise, but I've met him twice. And one time was at a kind of a residency directors forum type setting. And, I just name dropped you and Ashley because I hoped that would get his attention, and it did. And
one of them.
Mostly in good ways.
Yeah.
But the thing that really impressed on me was that he had said, where he was director at your program at the time at UPMC, he said, we follow the rules, we trust the process, and it really should be weighted toward the candidates, not toward the programs. And that just blew me away to hear. He was the first director that I ever heard just say it that plainly. Mm-hmm. And I don't know if he listens to your podcast, but if he does, I just want to say thank you, Dr. Burns, because it influenced the way that I want to lead our program.
Yeah, absolutely. You know what my favorite part of interviews is what? when students fail the social questions. We've had students before where you ask them so what do you like to do outside of podiatry? And there's
crickets.
Nothing. You got nothing. You don't nothing. Do nothing.
Yeah.
You should not fail the social questions. So.
Yeah, but some of them are tricky intentionally. But yeah, I always get a kick out of the some version of what's your greatest weakness, and when it's very clear that my greatest weakness is actually my greatest strength,
right?
Because I care too much or
Right.
whatnot, and I know students are so nervous, but yeah. So some of those social questions, it's just spend a little time preparing for those too.
Absolutely. So I thought it'd be interesting for us to kind of jump into some cases. Brad is I'm gonna anoint you the leading expert on MIS bunions in the country. All right, right now, ignore all the other people. This is the expert.
Do you have that power, Jeff? I don't know that you really do, but
no, that's why it doesn't matter what I say.
Yeah.
I don't even think is my computer. Is this even plugged in? Is anyone even listening? I don't think so. So I just shout into the air, nothing happens. But I think it'd be interesting for us to kind of go through some cases here. So this is somewhat controversial. And so right now in our profession, I think historically we've always gone back and forth about head procedures versus base procedures. And it didn't always used to be this versus that. It was all, it used to be a scarf versus a reverting green versus, the procedures might change, but then there's philosophical differences about how we attack these things. So I think it'd be interesting for us to kind of talk through what our thought process is on this and kind of give people a peek behind the curtain of what we're thinking about when we analyze these patients that are coming through our doors of our clinic. So this is a 35-year-old patient with mild bunion pain, pretty classic lateral deviation. She just had that painful bony prominence, but not a significant bunion deformity, not a huge IM angle. So certainly reasonable classically to consider a head procedure. So what are your thoughts when you see kind of a mild bunion like that, Brad?
Yeah, mild bunion. So, I mean, just a little history. So in our residency, or mine at least, I was trained on 3 procedures. The Austin, or a chevron, I should say, distal first metatarsal osteotomy, a Z osteotomy, or Lapidus. And I was told those are the only 3 procedures you're going to need to know. And when you get out there, you can apply them to any bunion and blah, blah, blah. So, I mean, yeah, you look at this x-ray with the history that you present. I mean, in general, it should scream a distal first metatarsal osteotomy. Whether or not you augment that with other things like an Aiken or a lateral release, I mean, we can certainly get into that too. But I think your base procedure is probably some kind of distal osteotomy, whether you're doing that open or MIS.
Sure. And so I have a different approach, but not too dissimilar from what you just said, because I was always taught a Lapidus or a chevron, or depending on arthritic changes, first J fusion. But basically, those are the 3 options to tackle the first ray. And so let's jump ahead here. So, we're taught, atavistic cuneiform. It depends on what you think is the etiology of the bunion. If you think the atavistic cuneiform is contributing to this, or whether it's not contributing to that, and you don't have to correct that at all. But let's just walk down this path and go through this surgical technique real quick for an MIS Lapidus. I've talked about it before, but we'll just kind of talk about it quickly. We use an MIS burr to obtain access to the first TMT and try to angle my burr to resect the wedge of the atavistic cuneiform so that obviously you're getting that angular correction. We'll talk about details of burrs and all the details here in a little bit. So we'll just breeze through that. But typically I make 2 portal incisions over the first TMT and use one to flush out the other. Again, I'm breezing through this because I want to get to Brad's thoughts. But once I've resected the cartilage, I microfracture with a drill, usually like a 2.0 drill or a 2.5 drill, and then pin in place and then put my final fixation in there. So especially important on the MIS Lapidus to not to make sure that you're not dorsiflexing on the lateral x-ray, which is prototypically common with these Lapidus because you're more likely to resect dorsally, whether you're making an open with a wedge. You can look at it, you make a wedge, you're going to have more taken superiorly than inferiorly, and you're going to dorsiflex the first ray. So ensure that you don't do that. So in this case, I did not do an Aiken. But I want to jump into a different case here real quick and talk about the alternative option to that, which is a head procedure. So if we're going to be talking about MIS here, what do you think is the optimal incision size? If someone's going to be tackling something through MIS, are you just trying to make, is it 2 millimeters, 3 millimeters, 5 millimeters? Are you making it big enough to get the pin across, the burr in there? What are your thoughts on that?
So for any students or even residents listening, there are specific definitions for percutaneous, minimum incision, or open procedures. And, percutaneous is, I guess, what I believe I'm doing with bunions. I'm making the smallest possible incision to fit an instrument in there, but you have no direct visualization on the osseous structure that you're working on. Technically, minimum incision surgery is you're still making a very small incision, but you have direct visualization on what you're working on. You can see the bone or you can see the joint. And so that definition is a little more gray because somebody's MIS could be 1 centimeter, it could be 5 centimeters. They're trying to make it as small as possible to do their incision or their procedure, but it's still not percutaneous. And then you have open surgery, which is just kind of everything else, or it's dissected wide open and you're staring directly at the bone. So I think those definitions are important because surgeons, industry, people are starting to try and blur those. There's companies that have taken their open stuff and said, oh yeah, it's MIS because now we're just telling our surgeons to make their incision smaller. Or, so when you're really talking about this stuff, you need to know which definition you're talking about. I guess when I'm doing a distal head procedure, I consider that truly percutaneous. I can't see the bone at all. Everything is through a poke hole in the skin. That's why I try hard to show the incisions that I'm using because those are different than an open or an MIS incision. And look, there's a gradient here, right? Like so. Open is more invasive than MIS, which is more invasive than percutaneous. If you look at it on that spectrum, you can still do a lot of damage through a percutaneous incision. And so, you got to be careful of that. But at the same time, if you're just purely looking at the incisions, those are the definitions that I work off of.
Sure. So I want to put these bullet points into all of our heads, and then we'll talk through this next case. So incision size, how many incisions, what size burr are we using, what RPM are we setting the burr to, do you use irrigation to prevent thermal necrosis, and then if we're talking specifically about bunion, either base or head, are we doing an Aiken, a lateral release, and then what are the complications? We know there's a high non-union rate for lapidus. And then there's obviously some other complications that come along with any surgery that we do. So let's put those things that to think about in our head as we move through this case here. You want to talk through, this is one of your cases here. You want to talk through your thought process here of what we're doing?
Oh, I would never do this. Yeah, sure. So, as you can see, on the left there, I guess you have your weight-bearing X-ray. This is what I would consider a moderate bunion deformity. Preoperatively, I try and measure the width of these metatarsals. I'll move that width over at the site of the osteotomy. And if it abuts the second metatarsal, or 1.5 of those widths can touch the second metatarsal, then I'm pretty confident that I can correct this deformity without having to do like a lapidus or something more proximal. So in this case, we chose to do a percutaneous distal osteotomy. You can see our burr coming in there. This is a 22 by 2 millimeter burr, Shannon cutting burr. And so you introduce that through a percutaneous incision. Typically, I try and put that in the distal metaphyseal bone right behind the sesamoid complex. Ideally, you want to angle this burr perpendicular to the second metatarsal. However, you got to look at the length of your first metatarsal compared to the second. So like in this case, I have just a little bit of angle distally. And you got to remember the burr is going to take about 2 to 3 millimeters of bone when you make that cut, as opposed to a traditional saw is going to take about 1 millimeter. So we make that cut. I got it slightly angled to account for the length. so that hopefully when I move that capital fragment over, we haven't lost significant length. We made the osteotomy, and now this is a tool that I typically introduce to start to stretch the soft tissues. And I'll introduce it in there, and I'll kind of push on the head, and it gives me an idea, A, of how flexible this head is going to be or how easy it's going to move over, but also, number two, it just starts to stretch some of the soft tissues that are attached to these structures. Personally, I'm a jig person. I learned freehand with these techniques, but I've learned how to use specific jigs as a tool, and it allows me to manipulate the head. And quite honestly, I've just used it as a tool that I can kind of hold the head and identify the right position for it. It also obviously has a aiming device for your screws. And a lot of times in these MIS cases, you need kind of multiple hands. So I've learned how to use this tool to just hold the head and fire my screws. And then you can see there we have two screws. So the first screw you place, it's extremely important to be bicortical before it goes into the capital fragment. And you want to be at least 1 centimeter proximal to your osteotomy. So in that middle image, you can see we're well over 1 centimeter proximal. And then in the image on the right, we have not only our first wire, but our second wire is actually bicortical before it enters the head. And the second wire doesn't necessarily have to be bicortical, but if you do make it bicortical, it's even more stable. Oftentimes, at least on LinkedIn or Instagram or other presentations from other surgeons, I'll see them put that intramedullary for the second screw, which is still okay as long as your first screw is bicortical before it enters the head. And then, once you get your desired implants in this case, we have two 4mm screws, which are pretty beefy screws. When I first started doing these, there was talk about doing a 4mm and a 3mm or some version of that. Now I pretty exclusively just do two 4mm screws unless I have a really small person. And once you get those in, then you can resect the spike. And I will typically introduce my burr through the same poke hole that I put those screws in. And so I'm not making an extra incision or an extra poke hole. We'll make a cut that's parallel with the medial aspect of the capital fragment. And then I'll usually just use a hemostat and take it out. And you can see in this case, we also added an Aiken. And I pretty commonly add an Aiken, I would say 90 to 95% of the time. And I've gotten a couple conferences where I've actually lectured on this now, but I think the Aiken is an interesting addition and one thing that needs to be explored more, as well as the lateral release in these procedures, because we know quite a bit with the Aiken in open surgery as well as lateral release for open surgery, but we don't know a lot about it in percutaneous or MIS surgery. So I think that's one area that we can continue to explore. I know there's a lot of MIS surgeons that don't add it, and hey, that's okay. But I have specific reasons why I add it. But on the image on the right, you can see kind of a final construct there. So what I shoot for is perfect sesamoid position, congruous joint, straight toe, and obviously that patient should have their bump removed. And there you can see the before and after.
So what are the possible complications? Because if you look, pretend you're looking at what the patient is seeing. All of a sudden their toe is nice and straight and the bump is gone. So they're happy as can be, right? That's what they wanted. No pain, bump is gone, toe is straight. But what are the potential pitfalls from doing this? Or, some surgeries have a higher learning curve, a steeper learning curve than others. So what are your kind of tips or pointers or potential things where this can go sideways?
Yeah, some of the biggest things that I'll see, or even that I experienced in my own early learning curve, was you got to put that first screw as far proximal as you can. If you don't start it there, when you don't have it bicortical, you will lose some of that correction, and that's extremely important. That first screw is the most important screw. By putting it so far proximal, it also allows you to get your second screw more proximal, which allows you to resect more spike on the medial side. So I think there's some that I see that, maybe they don't even resect the spike, or their screws are just so distal that they can't really resect much there. And, then you're trading like a osseous bump or bunion for a second osseous bump, because they're going to feel that prominence. And so that's one thing that I'll see happen. You can have a fracture of that lateral cortex, and specifically if you are trying to get your wires in the right spot and you perforate a bunch of holes in that lateral cortex, that's going to weaken it, and eventually it's going to fracture either intraoperatively or even after surgery when the patient's walking on this, because that's the whole point of this, is the patient should have the ability to have a very stable construct and let them walk immediately. Because if you're not letting them walk on this immediately, then you might as well be doing an open procedure, whether it's a chevron or a Z or a Lapidus or whatever you're doing open. They need the benefits of doing this MIS. And if they're not able to walk on it right away, they're not getting those benefits. Another common side effect you'll see is some degree of anesthesia, along the medial aspect of whether it's the bunion area where the screws go in, or even just the big toe. And that's probably the biggest, I would say, side effect that I see. Usually it's temporary. It's not a permanent thing, but patients will say, yeah, I got a little numbness along this area. And, eventually it goes away usually. But that's probably one of the biggest side effects that I'll see after these procedures. And I try and counsel people, before surgery about that. And eventually it goes away, but at the same time, it's something you got to talk to your patients about.
Yeah, I've seen the same thing when I do the MIS Lapidus. I've had a few people get some numbness that eventually resolves, but it is something where you stick the burr in there, and if you get too focused on the burr and the intraoperative fluoroscopy, you don't want to lose sight of the soft tissues. Yes, the burr is intended to do minimal soft tissue damage by the way that it's designed, but you can, if you are using this improperly, do some damage to the soft tissues. So you do need to be cautious, at least where I am back at the first TMT with the extensor tendon running through there and tib-ant, that we're not doing too much damage to the soft tissues. Don't take that for granted that, oh, it's just an MIS burr, it's not going to damage the soft tissues. You certainly can and will damage soft tissues. You have to be careful with that. Back to this head procedure, since there's not a lot of bony apposition initially, you're reliant just on the screws as your construct. So I would imagine that if your screws are perfectly placed, then it's a very stable construct. But if your screws aren't perfectly placed, then it's a very unstable construct. Do you see that as a problem at all for anybody? I don't know why you would, or if you see anybody, or if they talk about this of like, hey, my screws weren't perfect, and I let them walk on it, and it wasn't a stable construct because there really isn't much bony apposition there. Or is that not typically an issue because there's deep transverse intermetatarsal ligament, there's tendons, there's things still holding things together that doesn't tend to, like, it's not going to fly away. I tell my patients that, hey, this bone's not going to fly away. But do you typically see issues with that?
I mean, after doing hundreds of them, I don't personally see issues with it at the moment, but when you're in your early learning curve, I think there can be. And, when a new MIS user gets on LinkedIn or Instagram and they're just so excited about getting into the game and they post their x-rays, and you're like, yeah, maybe don't post those, right now, at least. Maybe get over that learning curve and make sure these patients are doing well before you post it. Or, I would even argue that the image you have up there, in my own case, these screws are too close together, the first metatarsal screws. So, if I were to redo that, I would space those out a little bit. Now, as far as I recall, that patient did fine, but like at the same time, there's things that you want to make sure, principles that you want to make sure you're following there that don't get you into trouble or don't get you complications for your patient. In general, this is a very stable thing, and that bone will regenerate and fill in over time. And I've done this on people in their 90s, people that probably should not have healed these osteotomies. And it's crazy how much bone they make. It's like a pediatric osteotomy that you just see like rain in with new bone. And when you first get started, it's a leap of faith. Like you're like, how is that ever going to heal? And maybe you don't push it 90 or 100% of the way. Maybe only go 50%. Just because you're kind of scared at first. But after seeing so many of these heal, and I've to date never had to take one back to like revise a non-union on one of them, and I'm sure I will at some point. But you watch all these heal, and you start getting a lot of confidence, and then you start pushing the envelope, and that's sometimes not good either. Like, maybe a procedure that should have had a lapidus, you're like, well, maybe I could push this a little bit, right, and see if it heals. But myself, I've been getting more and more into MIS lapidus. I know you've been doing a lot too, and let me ask you this. So you mentioned, you do a MIS lapidus. I'm assuming you're not doing MIS distal osteotomies then, or are you, Jeff?
Correct. I'm not.
Do you do distal osteotomies though, or
Not
at all?
anymore. I'm
Just
pretty
lapidus.
much lapidus or first MPJ fusion at this point. That you can make an argument that you're missing a subsect of the population that would benefit from a head procedure, but I'm decent at the lapidus. I'm pretty darn good at a first MPJ fusion, and those patients tend to do pretty well. So I think in my hands that a head procedure, because of the learning curve, I'm just not comfortable with that. I'm comfortable with the lapidus, so that's pretty much what I stick to.
Well, let me clarify. I had a question just to jump in there. Jeff, for your first MPJ fusions, are you also approaching that from a percutaneous or MIS standpoint, or are you a little bit of a mixed bag, or are you generally still doing those the open way, like I think many of us were trained?
Open at this point, which is changing as time goes on. Check back with me in a year, and I think that will be a different answer. Because I'm in the initial stages of that, but it's hard to move away from something that you have down to a science where I can make that incision, whack it open, boom, reamers, pin, put the plate on. It's like a little pit stop that's in and out. It's just you're so used to doing that, and then it's hard to veer away from your comfort zone to say, well, this is going to be a lot more difficult temporarily, but what's best for the patient. So. What are your thoughts on MIS, Devin? And what role do you see it kind of what role do you see it kind of taking on in our profession? Because it seems to be everywhere these days.
Yeah, no, I'm with you. I mean, I get to practice with the, as you deemed, the leading authority, but in Dr. Abicht here. But I would say, I've incorporated MIS and percutaneous approaches. My role here in my practice really has shifted toward a kind of a limb preservation service, and our diabetic and our vascular patients who are facing various forms of amputation. Certainly, I think there's a big indication for MIS in the realm of offloading plantar ulcerations, for doing your bumpectomies, if you will, for your plantar planing for Charcot's. I've done a number of those where these patients would really, I would rather not make big dissecting incisions on these patients, and to be able to do that through a percutaneous approach, that's been very helpful. And where I would love to see, how can I overcome the lack of elective forefoot procedures, because I'm just passing those off to Dr. Abicht, and I'm spending most of my time in the hospital and the wound center these days. How can I take that initial leap into a percutaneous approach for, say, a Charcot midfoot fusion reconstruction? I think there are applications, and so that's where I see it in my own practice, is using it for elevating osteotomies, offloading, trying to get ulcerations healed. And I had recognized very early. I mean, I don't even remember, Brad. How long have you been doing these? 5-6 years, something like that? Maybe not quite, but my memory tells me it's been a number of years. And I remember when you first started talking about this at our grand rounds with the residents and the attendings. I mean, it was, I think you were a little nervous because, we both trained here. We had the same attendings for the most part. And you're like, okay, guys, I know this is what you taught me to do, but look what I'm doing now. And I think that took balls, man. That was awesome. And
Yeah,
yeah.
there were words such as malpractice, crazy, never gonna heal, look for a
Yep.
different job. Like I said, it's a little scary at first, and
Yeah.
especially when you're not used to it. No one, I wasn't trained on these things in residency, and even when I went to like my first lab, I laughed about it because I'm like, what is this? I'm never doing this again. That was crazy. And then I sat there for the next month, like thinking about it and like trying to read more and investigate. And I'm like, maybe I'll try that again. And then it just kind of, you do a little more. And that's the thing. You start to get addicted to these things. And look, I do plenty of open surgery. That's the thing. Like if you probably see me on LinkedIn or Instagram, you think I only do uh, MIS and percutaneous stuff, but I do plenty of open surgery too. And I think it only makes you a better open surgeon as well, because if you can do these things through tiny little poke holes, you can certainly do them wide open. And we need that too for our residents. They need to see both, and our students too. And so hopefully that's the value that we're adding to the program.
Yeah, and I think my final thought was I think this is here to stay, and I think we're going to just see more and more of it in our training programs across the country, and I think patients are seeking this out. Our patients are the most informed patients I think medicine has ever seen because they have so much access and a greater understanding to a degree. I know, bear with me, there's a lot of you got to be careful with the information that you're trusting out there as a patient. But I think we're going to just see more and more of this. And when I recognized my uh, growing interest in the wound clinic side of practice, and I would say truthfully my waning interest in the elective forefoot, coupled with what I could see Brad here doing through an MIS approach. I felt like I was at a crossroads, and I had to decide I need to learn how to do this like Brad, or I need to get out of his way and start sending patients that way. And like I said, it really it coincided with my interest in the limb salvage approach. And so I still have very happy patients from my open bunion procedures, and people that are still willing to come see me and seek me out. But as my practice has shifted really over the last year or two into the wound center world, I'm just not seeing very many elective forefoot things.
I think that's an important takeaway is being able to understand how to do these open and MIS. Brad, you
Mm-hmm.
mentioned being able to do it MIS. You can certainly do it open. Most of us were trained on open, so we have a good idea of what the inside looks like, how deep the joint is, the curvature of the facets that you're resecting or whatever surgery you might be doing. And then being able to apply that to an MIS approach is certainly easier. If you know what it looks like on the inside, you can visualize it. So I think that's an important concept. So I want to thank you guys for hopping on tonight. I think this has been an awesome episode for people. I highly recommend the program there. I know that we're going to get students reaching out with more information. If they want more information about the program, Devin, where can they get that?
Yeah, absolutely. If you just go right to our program's website, available through you can get there through Casper, CRIP, through the DPM clerkships. If you just it's still accessible through GundersonHealth.org, or honestly, if you just do a search for Gunderson Medical Foundation, that's my sweatshirt here for those few who are watching. For the rest of you that are listening, just if you search for the Gunderson. Residency programs or medical foundation, and then they got a great website where you can navigate over to all the different programs, and specifically I'm assuming most of your listeners will be looking for the podiatry residency program, and right on there my contact information is there. They can email me directly. We have a program email, so that goes through my program administrator Allison as well. And yeah, we'd love to hear from you.
Hey, Jeff, I just want to say thanks for having us on, but also love this podcast. I love what you guys are doing here. I hope to see many more seasons of this, and I just think it adds a lot of value, another type of education people can have, and so keep up the good work. I appreciate everything you're doing.
Yeah, thanks. I appreciate that. Brad, you're all over LinkedIn, Instagram. We'll put the links in the show notes for people to kind of track you down and follow along with all the awesome stuff that you guys are doing. So thank you both for joining me tonight.
Yeah, thanks, Jeff.
My pleasure. Thanks.
All right, everyone. Thanks for joining us on another episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.